you can clearly see we're in Las Vegas, right? I'm here with my friend here, Raihan Faroqui. How you doing, man?
Doing well. Thanks for having me.
Nice to see you.
Appreciate it.
He is an internal medicine doctor, but doing extremely creative things. Please introduce yourself, Raihan.
Yeah, thanks. So Raihan Faroqui here. I first time attending the RPA conference. It's wonderful to collaborate with nephrologists. I serve as the head of clinical partnerships at a startup called Guaranteed Health. We're in the end-of-life care innovation space. We've had some great conversations here, especially on a lot of practices are looking for financial ROI. They're looking for kind of the next frontier in terms of revenue generation, working in VBC, and we work with a lot of kind of value-based nephrologists who are thinking about how do we kind of decrease the total cost of care in the last year of life.
Well, that last year of life is so crucial, right? I mean, we see so much, first off, we see so much suffering at that last stage of life and a lot of unneeded expense, right? So where do you see the application of AI in that last year of life and what your company is doing with that?
I think there's a couple of areas where we can think about, especially software and kind of predictive analytics being really helpful. So if you look at a panel of patients, let's say you have 10,000 patients, we're actually able to kind of predict mortality. So we can say, these 90 patients are eligible for palliative care, these 30 patients are eligible for hospice.
Because in the current paradigm, a doctor has to say, I think they have 6 months of life, based off just the intuitive nature of a physician, just to say that's what you think. But you're saying AI could actually give a more specific number to that, right? Or predict where it is.
I think AI is only as good as data. And as we know in medicine, data is historically siloed. So of course there's provider data that lives in EMRs. There's also payer data, right? And that's critically important. There's pharmacy data. So we can actually tap into all of these data sources and then make that prediction, based on age, chronic condition, terminal illness, and a variety of these other data sources, hospitalization trends, utilization trends, and then say kind of in advance, these are the patients that we believe have a 6-month mortality or even a 12-month mortality. And I think that's the key, when we think about end-of-life care, is we have to have that identification and these conversations happen far in advance, right?
Oh, 100%. Yeah, I think those conversations don't happen at all. And what is it like? So a large percent of the patients die in hospitals that never wanted to, right? And it's kind of crazy to me. So you guys are a predictive analytic tool, right? And that kind of helps with determining that. Do you guys provide any other support in that?
And I think especially for nephrologists, many practices do have APPs or even folks with a palliative care background, but many don't, right? So it's part of it is identifying the patients. So ESRD is a great place where there's very high mortality. Those who are comorbid with CHF or COPD, post-transplant, or sometimes the mortality rates can also be very high. Folks who've been on dialysis for more than 10 years, those are the patients where mortality is a lot higher. Those patients need extra help, they need support. So we basically deploy a team of palliative trained social workers, nurses, to have conversations in the homes of our patients, and then also leverage telemedicine and phone calls along with that process.
And you get the family involved as well too, or?
The family is super critical, right? Oftentimes I believe that family members are an underutilized asset in nephrology, in end of life, in medicine in general. We do a lot of education with the family members, the spouse, the child, and really educate them on serious illness, on the trajectory of these patients. We hear from folks all the time, our patients are not compliant with X, Y, and Z. Family members are an incredible compliance tool, right? Really leveraging them because they're in the home. They see the reality of patients. There's a lot of health inequity as well. Whether it's medication, whether it's care plan adherence. So we really try to educate family members as much as possible.
Well, I love the fact you're educating them because it kind of sets expectations that this is happening.
Correct.
I think so many people at that end of life are in shock that grandma died.
That's right.
And when you have that conversation, it's kind of expected. And you can actually take that end of life and make it more of a pleasant experience or a more reflective experience for the person.
And that's our goal. Our goal is to modernize the process. And we're very frank with our tagline is we should talk about death. We have to understand,
100%. Oh my God.
especially with these populations, that you will die from this process.
We'll all die, you know. Like, but
and we find like by educating the family members and the patient, it actually decreases anxiety and fear, right? When you're able to actually guide that process, it's really helpful. Multimedia is super critical. You know, oftentimes folks say, hey, we heard something, we were given a piece of paper, and that's it, right? Yeah. But if we are not actually continuous in our education, you know, so we leverage text-based workflows. Yeah. If you can text, again, the family member, kind of guide them through that end-of-life care process, right? Wow. Really, so that's been very helpful. And also, on the tail end, you know, we work with a lot of health plans as well. You know, so folks who are participating in CSNP, ESRD, you know, iSNP, Medicare Advantage plans, and also kind of doing JVs with ACOs, kind of, you know, these risk-bearing entities. They're also looking at building really good provider networks. So what we do is, as the kind of the care navigator, the care coordinator, we also leverage technology and AI to actually build a very high quality network. You know, we leverage data.
That's amazing. Yeah.
We take local, state, and federal hospice quality data, and now in any market we can say, hey, this is an A+ hospice versus a C+ hospice.
And oftentimes it's just like I think you talked about before. It's just relationship based. These referrals typically.
Typically, so like provider networks are relationship based, but they really should be based on quality, right? Yeah. You know, referrals should be based on who's good. In my area, and oftentimes that's hidden in data. Yeah. And most, you know, whether you're primary care or specialty care, you actually don't have that data to make that recommendation, right? That quality data. So, you know, we can surface that data, you know, for specialists, and you know, really educate them. Like in your region, in your market, these hospice agencies have the highest patient satisfaction rates. That's amazing. You know, they have the lowest hospitalization rate. You know, they're addressing pain appropriately. You know, again, that quality is super, super important, and you know, I think that's the beauty of being able to, you know, leverage data, but in a way that's usable by providers.
Absolutely. Thank you so much. Of course, man. I appreciate it.
Yeah,
all right.
Appreciate that.
Take care.
Wonderful.